Hi, Sonali. Hello, everyone. Hi, Harjo.
Hi, good afternoon, everybody.
Good afternoon.
Good afternoon. How is it going? We tried to log on. It was a bit difficult earlier to the main sessions.
Those are on live stream, so it is like bit challenging.
Yeah.
We have sorted out issues on the, during the break. Now it is working fine.
Okay, good. We are in office today.
Okay, great. Sonali,
Yes.
What about Nadika? Shall we start?
She is coming on. She's with everybody in another room.
Okay.
Yes. Good afternoon. I've joined already.
Great.
SFPA Sri Lanka. We had signing in problems.
Okay. Please put your camera on. Now forum is full. We will go live now, and we shall start the session. Rizwan, please take us to live stream. So good afternoon, everyone, and very warm welcome to everyone to this session. So today we have the session on how low did we go, the effort to end AIDS in Sri Lanka. So for this session, we have Sri Lanka team with us. They are going to talk about their journey, their learnings, and experiences on the HIV/AIDS prevention program they have been working on since many years. So let me introduce Ms. Sonali Gunar Sekera, who is going to moderate this session. Sonali is the Director Advocacy Family Planning Association of Sri Lanka. Sonali has a wide experience of working in development sector on sexual and reproductive health and rights, child protection, women's rights, and human rights. So she has been affiliated with many international organizations. Also, she has worked with very closely with many ministries, for example, Ministry of Women and Child Affairs and Ministry of Health. She has been advocating for the health rights of the people. Sonali has been a member of senior management team and represented many organizations at international forum. So Sonali, over to you now.
Hi, everyone. It's so welcoming to have all of you with us on this session. We will first invite Dr. Karavita, who will present the national program and the country situation. Dr. Ajit Karavita is currently serving as a consultant venereologist at the Sexual Health Center, Teaching Hospital, and Anuradhapura, and the acting head of institution of the Provincial Health Training Center in the North Central Province. He qualified in an MBBS from the University of Peradeniya in 1997 and subsequently obtained postgraduate diploma and MD in venereology from the PGIM University of Colombo. He's an honorary fellow and the past president of the Sri Lanka College of Sexual Health and HIV Medicine. Further, he is the chairperson of the Research Proposal Review Committee in MD Venereology and the editor-in-chief of the Sri Lanka Journal of Sexual Health and HIV Medicine. He's a visiting lecturer at the Rajarata University of Sri Lanka and the PGIM University of Colombo. He has worked as a technical consultant with FPA on national HIV grants for more than 9 years. I warmly welcome Dr. Ajit Karavita. Could you please come on and give us your presentation?
Thank you very much. Thank you very much for the nice introduction, and welcome you all for this small session, maybe about 15 minutes. So shall I share my slides from here?
Yes, please.
Okay, right. I hope everybody can see this, right? So this is actually based on the Sri Lankan situation about the HIV/AIDS. And so before that, we'll go through some of the statistics or some of the things in relation to the country. So it is a country in the Indian Ocean. You can see the figure. And the land area is about 65,610 square kilometer, and there are 9 provinces and 25 districts, and about 22 million people are living there, and density is about 337 people per square kilometer. That is 24th position in the world. And then ethnicity and the religion and languages all multi-religious, multi-ethnic, and multilingual country. GDP is about per capita is $3,830, and human index, development index is somewhat higher in comparison to the closer other countries. So we are placed at 72 position. So this is just about a little bit about the country profile. And let's move on to our figures about HIV/AIDS in Sri Lanka. Right. So in 1985, actually started the National STIs Control Program. But our history is dating back to 1843, I think. So that is during so very early stage started the anti-VD, the VD control program. And in 1987, we found the first HIV patient. And then in 89, we got our first local HIV patient. And in 2004, we started the antiretroviral therapy. And by the end of 2020, we had about 4,000 cases of HIV and 583 deaths reported, but registered deaths was 1,381. And almost 100 number of children were reported in Sri Lanka. And then when you look at this figure, this graph, you can see the number of cases reported over the years since 1987. So numbers are going up, and you can see that the male-female ratio is also, earlier it was very close, and by now you can see the number reported, males are very high than females. The male to female is like 1:4.6. So that is the level of male-female composition in the reported cases. But you can see the last quarter in 2020, actually, the reported numbers are low. There may be many other reasons. But when you compare with the 1990 and the 1920, there is 17% drop. But we can't just say that the numbers are going down, but there can be so many reasons for that. So when you look at the estimated numbers, so estimated numbers earlier, it was going up, and now it is flattened, and you can see the estimates are almost without changing over the last 10 years. And when you look at the new infections in the country is were high earlier, but now it is slowly declining to a reasonably good levels now. So we can see the 10-year drop is about 57%. That is a good sign in Sri Lanka to go to low levels. And then estimated AIDS death, you can see the numbers were rising earlier, but now the numbers are declining. So therefore, that is also a good sign for Sri Lanka to end AIDS in the future. And when you look at some numbers are still going up. So the reasons, there are many reasons. But out of that, there can be the number of cases, the case numbers are going up. That is a possibility. And also increasing testing. The tests are now escalated many times than the earlier. And so we are actually doing over millions of testing right now, and also introduced the rapid testing. And improve reporting, also improve the reporting system. M&E system has been established very well. And then with that, the reportings are also going up. So therefore, there are maybe, there are so many combination of factors that can lead to show these rising numbers. But we are not forgetting the possibility of new infections and hidden populations. And so we are working with the available figures, but we still believe that there can be, patients with the people who are hidden in the community and suddenly come out with infections. So there is a possibility out of all these statistics. And you can see the male to female ratio. So it has gone up to 1:4.6, as I mentioned earlier. So now the probable mode of transmission, we can see in 2020, the earlier heterosexuality is the main the mode of transmission, but now you can see that has shifted to the transmission mode to male. So it is about 47%, almost half of them are male to male sex. So that is a very important point for us to go ahead with the prevention programs. And so you can see there are, according to this analysis, so we can see some figures are missing to interpret. But anyway, so these are the two, heterosexual and the homosexual behaviors are the main two modes of transmission. Out of that, male to male sex figures are exceeding the female, the heterosexual behaviors. And mother to child transmission, of course, it's very low. And also ITU, you can see very low number, not reported cases in Sri Lanka in 2020. And so therefore, we are having these two behaviors mainly for our future work. And so these are the figures reported in the left side. It is per year in the 2020, and the right side, so it is from the first case to the current status. So you can see generally the numbers reported per 1,000 population. So these are still the Colombo, Gampa, the major cities are having more cases, and even the Polonnaru here, and so they are Putlam and this area are generally having more cases reported over the last years. Then the ending AIDS by. So we actually targeting ending AIDS. The UNAIDS is 2030, but Sri Lanka targeted a little bit earlier, 2025, to focus more attention and more emphasis on the prevention part, as well as the curative the treatment and care. So our target is still, we are trying that, but we can see now. So although we have this 2025 target, so that is a good start to go to 2030 complete ending AIDS. So therefore, what were the achievements so far? We look at going through the cascade, and you can see HIV treatment cascade. They are the first 90, and the second 90, and the third 90. I hope you know this. So this is the people who know their status. So you can see now 42 here, the percentage, and right now you can go through these years, and by 2020, 70% of people infected with HIV is known their status. So that is a good step forward, but our target is 90%. So this 70 is from the estimate. The estimate 3,700 people. So out of that, 70 already known their HIV status, and then so these are the numbers who received ART, and the people get the complete suppression of the viremia. So women and men, you can see there's a little bit different. So the status, they are known by 75%. So these are the people who know their status, and this is males. So when you look at these two graphs, you can see the females are tested more. Yeah, there's a reason, because we are providing universal screening for females. So therefore, they are getting caught in different the pregnancy antenatal screening, and then so their status, they know more than males. So that is the reason for that. And then when you look at the 2020, the 70% reached in the first 90, and the second 90, 83% reached, and third 90, the viral suppression 91 reached. So therefore, So we are still trying to go to 90, but we are close to 90. So I think in future we will be able to achieve these gaps and go to the 90 target. So this is a treatment target. It's not enough. The treatment target is not the only target. We need the prevention efforts, we need to strengthen the prevention effort more and more. And so this is just skip this. So let's go to this key population things. So we, as in other parts of the world, so we consider MSM, sex workers, IV drug users, and prisoners as our main key populations. And then we have a number of vulnerable groups, including migrant workers and witch boys. And then so these are the estimates right now we are working with. And female sex workers 30,000, MSM 40,000, transgender women 2,200, and PWID 900, Beach Boys 4,500. So these are the figures right now we are working with, but we still know that so these figures are also moving. So time to time we are conducting different survey methods, and the designs, based on the design, different figures came. But anyway, these are the figures right now we are using in consensus with all the stakeholders. And the countries, the HIV prevalence, you can see. So here, actually, Sri Lanka is in a good position in comparison to other countries. And so this is the prevalence of HIV among among MSMs, and you can see now the numbers are there's a small rise and there's a upward direction of cases. And so based on the female sex workers, you can see the numbers are not that very high in our surveys. So therefore prevalence is low in comparison to other countries in our part of the world. And also reported due to injecting drug use, you can see less than 5 cases reported, even 1 or 2, and that level of cases reported only in Sri Lanka. And so that's all about the HIV. So I just want to give you a small glimpse on this part, that is STI reported in Sri Lanka. So numbers are low. What I want to say is numbers are not that very high, but the number wise, you can see the genital herpes, non-gonococcal infections, those are the common inflammations in genitalia and the genital wall. So those are viral and non-curable part, the genital herpes and the warts. The syphilis, gonorrhea, trichomoniasis, and other STIs, so we treat them in our STI clinics. We have about 41 STI clinics all over the island, and so they can reach within 50 or maximum 100 kilometers per STI clinic. So this is the overall picture in Sri Lanka in about the HIV and the STIs. So these are the figures reported, and you can still see the STIs are also going down. So there is a you can triangulate these figures, because STIs are going down and HIV is going down. So we are in a good position to engage, but we have to do more and more. So thank you very much. With that, I stop my presentation. Thank you very much, everyone. And this is our website, right? Thank you.
Thank you, Dr. Karavita. I think you kept well within your time as well, and you gave us a lot of really useful information. I just want to tell the audience that we will be getting questions after the session with the others, because we would like all the question and answers to be put together at the end. I would now like to look at FPS Sri Lanka's contribution towards the national response. And I'd like to invite Nadika, who is going to give us the FPA overall contribution to the HIV program, the Global Fund grant, the summary of all the HIV grants. Nadika Fernando-Pillai is the project manager for the HIV prevention project for key populations implemented by FPA, and also the deputy director for HIV. She has been involved in the National HIV Prevention Project since 2012 and has been working very closely with the Ministry of Health, the Country Coordination Mechanism, many NGOs, CBOs, and key populations on SRH and HIV programs since 2002. She has played a lead role in ensuring community engagement and CSO capacity development. Nadika started her career in advertising and joins the social marketing program at FPA in 2002. Since then, she has been a key member of dynamic projects such as the National Condom Social Marketing Project, the World Bank supported Happy Life Contact Center using ICT tools, UNFPA Life Saving Project, External Migrants HIV Prevention Project, Innovation Fund Youth Development Project on filmmaking, and the Stamina Condom Launch Project. I would like to invite Nadika to present about FPA's Sri Lanka's contribution towards the national response.
Thank you, Ms. Sonal. Good evening, everyone. I'll be talking about FPA's involvement in the national response. I hope you can see my presentation. FPA, as one of the biggest NGOs in the country, have been making the largest contribution to the targeted key population interventions for many years. FPA has worked under the national program since like 1994, and all our programs have been aligned to the national strategic plan thematic areas. If you look at the strategic directions like HIV and STI prevention interventions, HIV treatment and care, STI treatment and care, HIV STI diagnosis, strategic information, health system, supportive environment. All our project activities have been aligned to the national program throughout our implementing period. If we look at, I'll take you through some of the milestones of our journey in the HIV program. FPA has started the first HIV prevention programs through its in 1984. And after that, FPA has implemented many key projects with the Ministry of Health, National STI/AIDS Control Program. Some of them are the Condom Social Marketing Campaign funded by the World Bank, then implemented the External Migrants HIV Prevention Project in internal zones. And some of other programs are like involved in the 8th ICAP, the biggest Congress on HIV, which was held in 2007. The entire FPA staff worked as the volunteer volunteer team in organizing, coordinating the volunteer program. Then in 2013, FPA becomes the non-government principal recipient, and for consecutive 3 grants, FPA have continued to be so. And 2014, FPA became the sub-recipient of the 3 multi-country grants funded by the Global Fund, and still continue to be the sub-recipient. In 2016, FPA has piloted the saliva-based testing project. Dr. Karavita was the lead person, consultant of this project. And in 2013, when we became the principal recipient, we introduced the centralized online monitoring and evaluation information management system for data reporting and recording to all CBOs and CSOs under the national program. This is something very important to us, because earlier it was all.
Nadika, sorry to disturb. Can you put your screen on full mode? It's kind of not on the PowerPoint. And Natasha would like to see your face as well.
Yeah, sorry, Ms. Sonali, I'm having an issue. I'm unable to share my video.
That's okay. That's fine.
Okay. The M&E system, the online M&E system, is one of our key features, because for the first time, like we've changed from paper-based systems, we trained all the CSOs on this online M&E system, and all our since then, all our data recording, reporting happens through this M&E system, because all peer educator services are recorded on a routine basis. All the coordinators of district level CBOs are trained to enter data on a routine basis through this system. And all performance-based incentives are also calculated through these systems. In 2018, through FPA, a new model was introduced. That is the case finding approach by Dr. Scott Berry. We have been introducing the peer educator model since the inception of the Global Fund key population-led activities. But since 2018, we've introduced the piloting of this case finding model. Global Fund trained the entire team and key focal points from the national program on the case finding model in Bangkok. This model was implemented in 2 districts, and after that in 2019, it has been implemented in the Epi Centre for HIV, that is Colombo and Gampa, which has the highest number of HIV cases. For the first time, through this model, HIV cases were identified. More than 30 HIV reactive cases were identified through this peer model that was introduced in 2018. We launched community-based testing in 2018. Then we supported and the facilitation, the development of the National Transgender Network and other key population-led organizations. We launched weekend FPA clinics for key population. We initiated night and hotspot-based clinics. And one of the other key feature is that our national M&E system will be developed using FPS M&E system. We have been doing advocacy and a lot of work through our advocacy unit and the 3 regional grants, ensuring enabling environment. There have been a lot of programs for legal enforcement and service provider training. This has been continued since 2014 and even now. We have been involved in all HIV campaigns that were happening in the past years. This Let's Talk is one of the ICC cricket HIV campaign with Kumar Sangakkara, the Sri Lankan cricketer. And the pictures show key cricketers that were involved in our HIV campaigns in the last years. FPA team has been actively involved in all HIV/AIDS programs and HIV prevention programs conducted by the national SCD programs. We have been a key player and we have been a partner who is actively involved in all of these activities. Also, FPA social marketing program provides island-wide condom distribution. So it ensures free access, not free access, it ensures easy access to condoms through its pharmacies, island-wide network. So even our key populations who are not willing to take free condoms or who want variation of condoms have access to all these pharmacies island-wide. That's how we have been supporting through our social marketing program that is been happening in all districts in the country. If you look at FPA today in the current national program, we are the subrecipient of the multi-country grant funded by Global Fund. A lot of activities have been done on community strengthening. These are photographs of the TG protection bill. If you look at the principal recipient role in the national project funded by Global Fund, we work with female sex workers, men who have sex with men, injecting drug users, transgender, and beach boys. These are the key population groups that we focus. We work in the grant, we work with many organizations under each key population category. And from 2019, FPA has been, the organizations have been transitioning from FPA to the government because this is a transitioning grant. So we start with more than 30 organizations, and now we only work with 20 organizations in the last year. There are 2 models implemented by FPA under this grant. One is the case finding approach. The other approach is the traditional peer-led approach. The case finding approach is done in the Colombo and Gampa Epi Centre of the Epi Centre for HIV and for MSM, female sex workers and TG component. We do hotspot mapping, web-based and real-time mapping. These are done based on the models we implement. Real-time mapping is done in case finding model. Hotspot mapping is also done in peer-led model. We're expanding community-based testing to all districts that we are under us. Organizations, CSOs are trained and are done under supervision of health workers in their districts. We've launched self-test. The government has launched self-testing, And we roll out assisted self-testing to ensure that all clients are linked to for treatment. We've also, the new activities identified and linking to PrEP. We've started a Sunday weekend PrEP clinic, and we are linking clients to the government for PrEP intake. We've also launched online outreach during COVID. This is the strategy we use to ensure the continuity of service delivery during COVID. We train our teams on online outreach. Our coaches worked with the teams and then trained them to find clients and provide HIV services and record them and then link them to clinics as soon as the clinics were open. We've also done HIV testing during COVID period. We issued curfew passes. We've got the support from police and other relevant departments, and we've done HIV testing in many areas during this COVID period. Online, if I give a summary of our online outreach activities, we've done during the lockdown periods, each team has done different activities, and there are different teams who have launched groups in social media. And then these are the groups. Actually, if you can see, there's different groups. Women's health group is a female sex worker group. Then trans support group is the transgender group. Then there is smart millennium boys, another MSM group. Likewise, there are different groups.
Can you hear one else? Push to one. Sorry.
Under this project, we provide the basic service package. It's the same basic package that we provide even for case finding model or the peer-led model. It's condom use and condom distribution, information awareness on HIV and STI, and referral or linking to STD clinics for HIV testing. These are the three services that we report and count under the Global Fund grant. If we look at the progress and the work throughout since 2013, you can see there is increase in some key population categories and there's a decrease. One reason TG is that we've introduced TG as a separate component in 2019. Before that, it was jointly reached as MSM and TG, but it was separated. And also after 2019, we have only focused on injecting drug users and not drug users as a whole. If you look at the PLHIV organizations, we have 3 PLHIV organizations working with us. They are Lanka Plus, Positive Women Network, and Positive Hopes Alliance. We ensure through them, we ensure the PLHIV members receive ART from district SCD clinics. And we ensure even during COVID period, these organizations, especially Lanka Plus team, has worked in delivering ART to the people in restricted or the areas who did not have access to SAD clinics. So they ensured that people received ART on time, even during COVID restrictions. If you look at, this is reported through our MEIMS. And if you look at the system, as of today, it shows that we have 3,587 men having sex with men received services by now. 4,685 female sex workers received services by now, and 771 injecting drug users received services by now. As of now, all these data are routinely entered by our district level partners, and they enter data on based on the calendars they collect from the field, from the peer educators or the outreach workers. If you look at the Sri Lankan map, this shows the Epi Centre for HIV, where FPA is currently focusing, and FPA will continue to focus in the new grant as well. That is Colombo and Gampa districts. All the other districts will be implemented under the direct supervision of the government National STD/AIDS Control Program from next year onwards. According to the system, we have provided 36,800 services to members, and also we have done 11,966 referrals on HIV testing. Thank you.
Thank you, Nadika. That was a very, very interesting session, and you gave us a very good overview of the situation where FPS Sri Lanka has been working on the Global Fund grant. We are now coming to I would say, the more another very interesting part of this program, and that is the Q&A session. And in this question and answer session, we will be hearing from many people about what they're doing in the grant. So let me first introduce Niroshan, and he is from the PLHIV community. Niroshan Senadira joined Lanka Plus in 2011 to volunteer to work with the PLHIV community. He's currently the chairman of the organization and has been working closely with government and non-government organizations such as NSACP, FPS Sri Lanka, and he's committed to the good of the community. He also represents the CCM of Sri Lanka on behalf of the PLHIV community. And over the years, he has gained experience both locally and internationally in this field. And through his vast experience and skills, he hopes to continue to serve the community. Niroshan, can I ask you two questions? My first question is, do you think that Sri Lanka is on track in achieving the 90-90-90 goal?
Yeah, thank you, Ms. Sonali. My nice introduction and for giving me this opportunity. Based on the data published by the NSACP, Sri Lanka has shown a gradual increase in the percentages of PLHIVs who know their status. 2017, 43%, 2018, 53%, 2019, 64%. Based on these trends, I believe that it is possible for Sri Lanka to achieve the 90-90-90 targets, provided that health authorities and CSOs working in the field of HIV remain vigilant and continue to raise awareness and increase testing while paying attention to any unforeseen challenges, and example, COVID-19 pandemic.
Thank you, Niroshan. I have another question I'd like to ask you. Any specific areas that the national program or FPS should focus in the future programs, keeping in mind the pandemic that you have just mentioned?
I believe that the NSCCP and FEA should focus on the following. First one is need to implement an effective ART delivery system to mitigate any reduction in access during any future travel restrictions. Second one is a system to mitigate any loss to follow up and for ART by PLHIVs. Last one is an online support system to facilitate the provision of services such as counseling, information pertaining to HIV and ART and etc. Thank you.
Thank you, Niroshan. I'd like to invite FSW female sex worker Kanti Abekon. Kanti Abekon is from the Community Strength Development Foundation from Colombo. She's the program coordinator and deputy director of the CSDF. She's one of two founder members of the CSDF. CSDF is a non-profit making NGO established in 2003 and working for female sex workers. From the origination of the organization, Kanti has been involved. She has 23 years of experience working with FSWs. Currently, she is the vice chairperson of the CCM subcommittee and closely works with the national program. She's working with North and East Women's Group on their issues and reporting to the CEDAW committee with experiences on the NGO CEDAW reporting committee members in Sri Lanka, focusing on FSWs. Kanti, I've got two questions for you as well. My first question is, you have been implementing peer educator model and case finding model in Colombo. What challenges have you faced in implementing the case finding model with female sex workers?
Good afternoon. Thank you for welcoming me to the program. And currently we are using the case finding model for working with female sex workers. And we know that there are in Sri Lanka, there are very few HIV positive female sex workers. So we have to do a lot of HIV testings among the identify HIV positive female sex workers. So and also another thing is currently we are doing a lot of HIV testing, but we have to provide HIV preventive service for the FSW while we are doing case findings strategy. So it is very difficult and it's very challenging for us because one outreach worker has to cover up more than 200 female sex workers during this year only, in 2021, except 2019 and 20 we have to do a lot of coverage them. So we need to meet them, we need to identify them, we have to at least we have to provide condoms among all of sex workers. Sometimes street-based sex workers don't have enough facilities to keep condoms with them, so we need to meet them at least twice a month at their places. So it is very difficult for us. And also we need to identify new FSWs also. So I think it's a very big challenge for us, but we are doing it. Another thing is condom is keeping condoms with them also is a challenge for them. So we are identifying a lot of new strategies for keeping condom in their places, like condom depots like that. So we are finding solution for that also. But it is big challenge for us. And also during this COVID situation, it's we have to work very hardly to go to their places, and because we identified that a lot of sex workers have moved their traditional model to the online base. So we are facing a lot of challenges to meet them at their familiar places. It's like a big little bit hidden them during the COVID situation also. I think that case finding model and peer education. Currently, we are not having a peer educator model working with in Colombo district. We know that there are nearly 8,000 sex workers on our experiences in Colombo. So we have to accept a lot of sex workers we have met already in 2019 and 20. So, but we are providing services to our DIC. So we have to increase sometimes DIC staff, because we have only one DIC staff providing services to such a lot of FSW community. It's a big challenge.
Thank you, Kanti. I think we're running short of time, but can you very quickly give us your views on the second question? FPA with the national program has introduced new strategies to reach the FSWs. What are the successful strategies that you have used, and which areas should the program improve in the future?
When we're talking in the new strategy, we have received a lot of testing options. We have started DIC testing and also self-testing, and also we have opportunity to escorting female sex workers to NSACP, STD clinic in Probable like that. So it was a very worth for us. Well, because they have a lot of options for testing, and also online system also we have one outreach worker for Colombo, so it's also very helpful for us. It was a very successful, I think. And also we have a lot of CBT testing options also. In per week we have 6 days we have testing days. It's also very helpful us. And also we need to increase we have no such most opportunities for testing STI because we are doing only testing, rapid testing like that. We have to increase if we have rapid testing for STI at least at our DICs, it will be very helpful for us, because a lot of sex workers are in need of doing STI screening. So I think these are where if you DIC also expanding DIC facilities with like such kind of facilities, it will be very helpful.
Thank you so much, Kanti, for your answers. We can next go on to the men having sex with men component. It will be Manju. And I'd like to introduce Manju Heman, who's been working for LGBTIQ community in Sri Lanka for more than 12 years. He has played an active role in fighting and advocating for rights and human rights of the community members. He started his journey with Companions of a Journey and joined Heart to Heart in 2012. He is the key population focal point, and he's also a CCM member. Currently, he is involved as the KP coordinator of the Colombo sub-recipient of the National HIV Project. Welcome, Manju. Can I first ask you, Sri Lankan data shows a rising trend of male-to-male transmission. What are the strategies introduced by the national program to address this? And what are the initiatives your organization has been involved in?
Thank you, Sonali, Miss. We are using a case finding model. In that model, conducted night mobile clinic and hotspot basic clinic and clinic at the parties. Conducting increasing community-based testing and increasing self-testing and community conducting increasing in the self-testing and assisted self-testing, increasing client who not the use condom to KP PrEP clinic at the online outreach. So Alice Mangtan एक अभ्यास करे आपी यार विशेषण में करना self testing एक सहा विशेषण night mobile clinic एक आपी में मैंने तो क्रियात्मक कर लगी ना एवं में condom use न करना आपे KP प्रजावे आये तो विशेषण PrEP clinic एक आपी एक टा हंगुना दिलाती ना में model लेके आये तुले.
Nadika, would you just like to give a brief summary of what Manju just said?
Yes, Manju said that one of the initiatives, few of the initiatives are, one is doing assisted self-testing and self-testing for committee members, then doing expanding community-based testing, and also doing hotspot-based and night-based testing. So these are some of the initiatives, and also they've identified clients through this case finding model, and the clients who are not willing to use condoms have been linked to the KP PrEP clinic conducted by the national program. So those are some of the initiatives done recently, and he believes that with those he'll be able to reach to many people, and also the online approach, because a lot of people, young MSM community members are in using young dating apps and other apps. So online approach also will help in reaching this key population and contribute in ending this MSM epidemic.
Thank you. Manju, mata tawa prashnak. I have another question for you, Manju. With the rising MSM epidemic and pandemic challenges, what are the 3 key areas the national program should focus to reach for the high-risk MSM community?
ඒකදී පළවෙනි key point එක තමයි outreach worker. ඒ වගේම දෙවෙනි එක assisted self esteem සහ විශේෂයෙන් අර holiday clinic and night clinic අපි එකට යෝජනා කරලා තිනවා ඒ විශේෂ මේ area තුන වශයෙන්.
Yes. The 3 areas that he feels are the online outreach, that is one thing. The second is the assisted self-testing, because this is done by the outreach workers. So the outreach worker gets the opportunity to meet the client at their preferred place and do their testing. And also the facility-based testing, to have it on holidays or weekends or nights. Those will be free, easy access to key population members.
Thank you very much, Manju. Thank you. We'd like to go on to the next person, and this will be Mahesh, and he is representing the people who inject drugs. Mahesh Nisankar. He is currently working as the district coordinator for PWID component of the GFA grant, professional counselor on drugs, alcohol and other addiction in Alcohol and Drug Information Center, Epidemic, with over 20 years of experience of providing consultation services in the government and in the private sector on drug prevention. He is a former senior technical officer on drug abuse management and community consultant for the Global Fund. He is closely working with the government sector as a consultant and a trainer with the Government Rehabilitation Center, Bureau of the Commissioner General Rehabilitation, on the rehabilitation process for injecting drug users. Thank you very much, Mahesh, for joining us. I have 2 questions for you. My first question is, in your long partnership with FPA and the national program, what do you think have worked well for injecting drug users?
Yes, good afternoon to you, Sonali, and I would like to express my gratitude to you for inviting me to this important interview. So I'm Mahesh. My answer to your first question is, peer-led intervention. That is the method which we have been used to reach injecting drug users as well as drug users in the past, right? In terms of peer-led intervention, we are using their own peers, their own members in their subculture to reach them, right? That is the most attractive way to use key population like drug users. So I have a long-term experience by using peer-led intervention. Firstly, I started with UNODC H13 project to use peer-led intervention. That the objective also the same as Global Fund, preventing HIV/AIDS transmission via drug users. So in that project also, the splendid outcomes testifies to the success of peer-led intervention. And in terms of sustainability of that method, even after end of the project, so you make sense, what do I mean? Even after end of this project, peer educators will function as the same, in their same community, as community members, right? They are not outsiders. They are this peers of those community, then they will function. And in terms of drug users, in terms of injecting drug users, they are not hesitate to declare their current status to the peer educators, because they are own members, right? They are brothers, right? They are declare their current status of drug use without any hesitation. Just imagine if we try to expose them to an outsider, they never like to expose their status, especially to the government sectors, right? They are scared of even they're scared of to Grama Niladaris, because the police always try to arrest them, right? Then they never trust outsiders, right? They trust only their members, right? They trust only their members. That is why we are using peer-led intervention in this project also, right? And other thing is, when the trust built properly between the peer educator and the clinic staff, they will direct without any hesitation. They will direct clients without any hesitation to the clinic, and they are maintaining healthy relationship, right? Healthy and nice relationship with the STI clinics, right? So again, I can insist my answer to your question is peer-led intervention.
Thank you, Mahesh. My next question for you is, what are the biggest challenges in reaching injecting drug users with quality peer-led services in Sri Lanka?
There are many challenges. The one is myths and stereo. I call it as myths and stereotype thinking pattern of the community as well as the police and other law enforcement, right? They think the drug users are convicted criminal, right? Then drug users are always arrested by the police, even without drugs in their pockets, right? The people, the community also think, community members also think the police can do anything to drug users because they are criminals, convicted criminals, right? They don't have any rights as others, right, to survive, right? They think they are convicted criminals. Then that is the first and huge challenge. The second one is Sri Lankan government conducting compulsory rehabilitation centers, right? So when they got caught to the police sent them to the court, and they are sent to those kind of rehabilitation centers without their permissions for a long period, for 1 year, for 2 years. They have to be there for a long period from their lives, right? They are very scared of those kind of things, right? That's another major challenge, right? And other thing, in accessing other services, right? In terms of accessing other services as other people, they don't have right to access those kind of services freely because of that label: drug user, criminal, likewise. And in this situation, right, recently they have another label: COVID spreaders, right? When we talk about drug users, all I think they are COVID spreaders. They are spreading COVID to the other people. Likewise, then their rights are violating maximally by the law enforcement and the community, right? Those are the challenges what I can mention, right? That's it.
Yeah, thank you, Mahesh. That was excellent.
Okay.
We are now having to go to Bhumi, but because of the issue of time, Bhumi, I'm going to be able to bring you in to talk about both the national program and the regional program. But before we do that, I'd just like to ask Sriyal to first come in to explain what the regional grant is about. And then I'll bring you in, Bhumi, and then we will introduce you, and then we will have both programs where you will be talking about. Is that okay?
Yeah.
Okay. So Sriyal, I'm just going to introduce you first. As we move on to the regional grant, which is the advocacy grant of the Global Fund, and we've just finished the program, which is the service implementation of the Global Fund program. We are now moving on to the advocacy part of it. I would like to bring in Sriyal. He is the program officer of AFAO at FPASL for the program funded SKIPA regional grant managed by AFAO. He's a member of the LGBTIQ community and an advocate for PL/HIV rights in Sri Lanka. So I'd like to first bring on Sriyal and then next you, Bhumi, if that is okay. Yeah, okay. Sriyal, would you like to tell us? Yeah, okay.
Thank you so much, Sonali. I am now going to take time with the presentation, but I will briefly explain what the SKPA program is. The SKPA program, or Sustainability of HIV Services for Key Populations in Asia program, is a multi-country regional grant that is being implemented in 8 countries. Currently, Sri Lanka is one of the sub-recipients, and FPA Sri Lanka manages the SKPA program for Sri Lanka. The objectives of the SKPA grant is to increase financial sustainability for HIV services, strengthen strategic information, mitigate service delivery gaps, strengthen community systems, and contribute to enabling environments. As a part of our initial efforts, we carried out a review of the package of HIV services for key populations in Sri Lanka, which provided 23 recommendations for the national program, Family Planning Association, and the SKPA program to take on. Out of these 23 recommendations, about 16 plus recommendations were either taken upon or acknowledged by the programs. And we have seen a lot of progress post the review within the national program and the services that were provided. As we now currently understand, a lot of the HIV estimates and projections were revised. Materials that were previously developed were used to enhance KP programs. Increase and demand for PrEP and HIV self-testing was taken upon, and community engagement for PrEP through CSO collaborations were taken upon by the national program. The scaling up of community-based testing services was one of the recommendations that was provided. And similar to this, improving the general care and the service package improvements were gradually taken upon by the national program, and we have seen much improvement over the years since these recommendations were made to the national program. Apart from that, we were operating during the COVID situation, and we were quick to sort of jump in and provide IT service support for VSRs that were operating at the time. We provided them with routers for all of the organizations so that they can carry out their day-to-day operations. We carried out a 3-day training program virtually for the organization members in order to manage their work online. It was a very basic training, but a very useful training, so that given a environment of new normal, we supported organizations and their staff members to get on to the program and be able to carry out their work. Apart from that, we also worked with Dr. Tiloma in order to do a gender assessment of HIV services, which produced a set of recommendations for the national program and FPA in order to accommodate the key population needs and understand some of the gaps that were previously unrealized or previously were existing, but we managed to sort of highlight them again. And a few of the activities that we took on from that recommendations were to develop a guideline for gender-based violence and guidelines for peer educators to identify suicide ideation and self-harm among key populations, PLHIV, as well as LGBT community members. We also carried out a study on sexualized drug use and the risk of HIV. It was not something that we had seen before, but I think Dr. Tilo will explain a little bit more on that when she's speaking. Apart from this, we also initiated discussions with Pro Bono, a legal pro bono organization, on how to address the penal code criminalization of same-sex conduct, and to work on a decriminalization proposal that is currently undergoing and has been transferred from our program to FPA under accelerator grant that is being now taking on that work. We also have been working on improving TG health services, improving the knowledge that is provided in the region in terms of translating documentation such as helpful information on being transgender, but as well as health manuals that are being developed by the Asia Pacific Transgender Network. So we also have hopes of carrying out a couple of training programs in the future for healthcare providers as well. And also, Bhumi will speak to this, establishing a TG health center in Sri Lanka, which is community driven and led by community members in Sri Lanka. So I'm not going to take any more time, but this is an overview of what we have been offering so far. I will let my other colleagues explain further.
Thanks, Riyal. So we will move on straight to Bhumi. And I'd like to introduce Bhumi. She's a transgender activist in Sri Lanka who openly fights for LGBTIQ rights. She's widely known for her public discussions, raising awareness about transgender community to the society. I'm going to summarize her CV because she has done so much, but I'm just going to tell you a little bit more. She is the founder and the executive director of the National Transgender Network in Sri Lanka. And she's a subcommittee member of the Human Rights Commission, LGBTIQ, and steering committee member of the Children's Parliament. And her final objectives are going to be: every trans Sri Lankan is awarded a life of dignity and under eyes of the law and society. So I'm handing this over to you now, Bhumi. You have a big job to do. You've got to represent the national program and the regional program. But let me first ask you a question from the national program. Can you describe your journey as a TG organization in the national program?
Thank you so much, Sonali, for that lovely introduction, and also the opportunity to talk about and share about our thoughts and experiences. If I'm not mistaken, in 2015, during the midterm evaluation of Global Fund national program, we have raised some sort of practical issues that we have been facing to work with the MSM community. So, both communities were not that much comfortable to work together, and there were like some sort of attitude and conflict issues. So we have raised that issue, and we have asked support to build up a separate network of transgenders under Global Fund project. So as a response of that request, Global Fund have supported us through Family Planning Association to create the National Transgender Network as an independent network. So the support and the guidance that we have got from Family Planning Association and Global Fund is incredible, because they are still supporting us to drive as an organization in the correct path. And HIV prevention is one aspect and one area that we are working on, but also the empowerment, legal acceptance, making available the all social services for transgenders. And yes, currently we are working with the regional grant to bring the protection bill for transgenders in Sri Lanka. So as an organization, that is our past journey. Now we are 3 years old. So yes, I think as an independent network who is trying to cover the entire island, we have so much far to go and achieve. Yes.
Because of time, Bhumi, I'm going to go into the regional grant now. Could you tell us a little bit about the Transgender Protection Bill and how this bill will change the life of TG persons in the future?
This is one of the experience and inspiration that I got from my other Asian country friends. When I went to international conferences, the discussion that I had with the Pakistani friends and also from Indian friends, that they have asked, like, why, Bhumi, can't you try and get something kind of a bill to Sri Lankan transgenders for their protection? Because all the time the discussions and the sensitizing programs that we have done, it's kind of a putting a plaster on a wound or like a place which is damaged. You know, like it's not a solid solution for the problems that transgenders are facing on. And as we all know, we don't have as a community a solid recognition within the systems and also within the law field in legal areas. Sorry. So with the support of regional program, we are blessed to move on with the provincial discussions with the community members to get their inputs for the transgender protection bill, which will leads to another consultations after the community consultations. So we are in a good track and it's running very smoothly. So hopefully we will be able to do all other consultations with law reformers and Justice Ministry and other media companies as well. So this will bring a huge light for transgenders persons' lives in Sri Lanka. They will be, you know, having an opportunity to have a life with dignity and respect. Thank you.
Thank you so much, Bhumi. I think you may get some other, you know, kind of questions that you could answer. I'd like to move on to Dr. Tiloma. And Dr. Tiloma is a medical doctor and board certified public health specialist. She has closely associated working with FPASL as the former country project coordinator and the EU IPPF SAARC project on advocacy for SRH HIV integration. She's also been a national consultant for the Global Fund multi-country South Asia regional UNDP project on HIV prevention in MSM and TG persons. And she has conducted the 7-city study on programs and policies impacting the health and rights of MSM and TG persons. She was a co-consultant for the regional review of HIV legal and policy environment in Sri Lanka. Since 2018, she has been a gender consultant to the AFAO Skip Up program at FPASL. Welcome, Dr. Tilo. I'd like to ask you first, as the lead consultant for gender on the regional project, could you explain what has been achieved with regards to gender? Dr. Tiloma, are you online? Maybe until she...
Please unmute.
Dr. Tilo, you're muted. Can you hear me now? Yes, yes.
Okay, okay. So thanks, Sonali, for that kind introduction. To respond to your question, I think the most important achievement was conducting the gender review of HIV and key populations in 2019. Because this not only provided information towards strengthening national efforts to achieve the global target in 2030, to me, it was, I think, more important that it provided insights of the communities on issues that negatively impacted their well-being. So it provided information for program planning at a more community and individual level. Now, some of the issues identified in the review was the need to address internal stigma. And this is something that has kept recurring all these decades. And also gender-based violence, self-harm, and suicidal thoughts and attempts. And the sexualized use of drugs, which, as Sri said, is something that is now emerging. It also identified the need for gender and rights-based inputs in the secondary school sexuality education program to protect adolescents, especially gay and transgender adolescents who will otherwise fall out of school and then take to a livelihood of sex work, exposing themselves to HIV risks. And this is all due to the stigma, discrimination-driven violence that is directed against them by teachers and their peers in schools. The gender review also identified a perennial issue where the necessity to safeguard the dignity and rights of communities by advocating for constitutional recognition of gender as a grounds of non-discrimination in addition to sex, and repealing laws that criminalize same-sex behaviors. In addition to that, the need to strengthen policy coherence at high level, especially at the National AIDS Committee, to ensure better access to basic necessities of education, employment, and housing for key population communities. Something that was very concerning to me was that the review showed that within a society like ours, where the LGBT and KP groups are looked at in a negative way, that the communities were themselves stigmatizing their members who were testing HIV positive and were found to be engaging sexualized drug use. On a slightly different note, respondents in the review were also concerned about issues like this, like the lack of residential care facilities for aging and destitute KP members. We need to remember that Sri Lanka has the fastest aging population in Asia. And anyway, we have inadequate services for elderly. So elderly from these KP communities will not be accepted in the available facilities. So this is something that has been flagged in repeated activities in discussions I have had with the community since 2018. And I think somewhere down the line, this has to be noted for address. The other challenge that was advertised was the continued difficulty in linking with hidden subsets of the KP community who do not join mainstream HIV prevention activities. So there is little or no information about them, even in the NGO sector or in the national service providers. So in brief, so those are some of the issues that came up in the gender review.
Thank you, Dr. Tiloma. I don't think we have time to go for the next question. I'd just like to bring on Ranaka. And Ranaka, he's the project officer at FPSL for the GF-funded SKIPA project. Ranaka, you have 1 minute to tell us about the community strengthening program of the regional project. It's a very interesting part of the regional project, and I don't want that to be missed out. So could you just tell us very briefly, what have you achieved in the work that you have supported on the community strengthening of the organizations, KP organizations?
Thank you, Sonali. Let me get straight into it. So we did an IT webinar series back in December 2020, and the training was provided for the 27 CSOs that we are working with in the national program. And basically the training was divided into 3 levels to cater to the CSO staff's different knowledge levels. And the 3 levels were basic, intermediate, and advanced. Out of the IT webinar series, we were able to train 201 participants. And in August 2021, this year, we started the CSO capacity building and strengthening activity. And this was done mainly to help the CSOs that are working with the national program transition to the government program as a strengthened and capable organization, and to increase the capacity of their staff in key areas. The key areas we focused in this program were governance management and M&E, finance and HR management, communications and advocacy, and resource mobilization. So basically, we did a rapid assessment survey with all these organizations, and to get an idea what sort of knowledge they already have, and the templates were made based on this rapid assessment survey. And we did general workshops through Zoom. Most of them were virtual, and some of them were one-on-one discussions, especially in areas like communication and advocacy. They chose to do one-on-one discussions. All the other sessions were done as general workshops to cater to all the CSOs. So through the governance management and M&E sessions, the basic governance management and M&E knowledge was shared, and it helped organizations to reevaluate their objectives, goals, missions, and mission. And it helped CSOs to prepare strategic planning on governance management and M&E. For finance and management, like governance management and M&E, the consultant held sessions to share knowledge on finance and HR, and it helped the CSOs to prepare finance and HR policy documents. Communication and advocacy did one-on-one discussions with the organizations, and it helped the organizations to realize whom do they want to reach through communication, and what message they want to deliver, and what platforms they would like to utilize. And based on their needs, they did a short skill building sessions on Instagram and Facebook, and how to reach people through Instagram and Facebook. And then again, they did a few sessions on Google Forms and analytics. And they introduced another donor-find platform, a local one called tribefund.lk, where you can post your fund requirements so that donors will fund you. And additionally, the CSOs were introduced to regional KP networks so that they can keep in touch and get to know what other organizations in the region are doing. For resource mobilization, the consultant held workshops to increase the knowledge and importance of resource mobilizations for all the CSOs. And the consultant is currently hoping to have one-on-one sessions physically with all the CSOs to cater to each and every CSO's need and capacity. There you go.
Thank you, Ranaka. Thanks for keeping on time. I've got now 3 questions, but I've been told I can't ask all 3 because of time. But Dr. Ajit, a question has come up.